Yeah.
Good evening, everybody. On behalf of Clinical Infectious Disease Society India and the Cardiological Society India Mumbai branch, it's a pleasure to have this first symposium CME today evening on device-related infections. And we have been, SIDS has been doing this activity with different societies, and it's a pleasure to be with Cardiological Society and the senior cardiologists from Mumbai being a part of this program. And we have senior ID consultants also being a part from the SIT Society. So I think without and on Dr. George Verghese, he's our president. On behalf of them, I'm speaking because he's not able to join. He's slightly occupied somewhere else. So I welcome you all, and I hand it over to Dr. Bhavesh, and we look forward for similar CMEs in future as well. Bhavesh, over to you.
Yeah, hi. Thank you so much. I think we at CSI are very happy to organize this joint meeting on such an important topic, and I want to thank Dr. Nagvekar and the entire SITS faculty for being here. And as you know, we very regularly have CME meetings from CSI Mumbai branch, and this with the new committee starting from February this year. This is our first academic program, and we have many more to come. I now ask Dr. G.R. Kane, our new president, to say a few words, and then we can start the meeting.
Good. Welcome, everybody. It's a real pleasure to have CIDS people with us. And I actually wanted to give a sort of a small overview of what things are expected, just to give our people, the members of our branch. So a number of programs we have planned. So we geared up to discuss, learn, and teach. So we have programs coming up on AMI, amyloidosis, journal club, postgraduate training for students who are doing DM, DNB, and multiple other things. So shortly we'll come back to you again and again with the new program. So with that, I hand it over to Milind to carry forward this program of today. Thank you.
Good evening, Dr. Kane, sir. I think your vision is going to really get this branch very far in the next 2 years. And we have a galaxy of experts here today. And we have the program is as follows. First, we will have an overview lecture by Dr. Ram Gopal Krishnan. Then we will have 2 case presentations. Then we will have a short lecture from Dr. Kaushal Pandey on the surgeon's perspective. And after each lecture or each case presentation, we have kept time for discussion. So we'll have adequate time for all comments and discussions. And at the end, we also have separate time for panel discussion and audience questions. So without much ado, I would ask Dr. Neha to please introduce Dr. Ram Gopal Krishnan and start the first lecture. It's exactly 8:35, so we are on time. I also request all the speakers and the chairpersons to stick to the time limits. Dr. Neha, please.
Thank you so much. It's my pleasure and honor to be part of this first Clinical Infectious Diseases Society and Cardiology Society of India collaboration. And it's my pleasure to invite Dr. Ram Gopal Krishnan, sir, who is a pioneer in infectious diseases and has been supporting organizations in overcoming their infection-related challenges. Sir is senior consultant in Apollo Chennai and has close to 4 decades of experience in infectious diseases. He has been the teacher for FNB infectious diseases and now DRNB infectious diseases. And he's going to share his knowledge regarding clinical approach to cardiac device infections. And to moderate the session, I invite Dr. Vinay, who is senior consultant in Apollo, Bangalore. May I
Yes,
request
from cardiology side, we have 2 experts, both electrophysiology and device experts. We have Dr. Venkat Nagarajan, who is a senior electrophysiologist from KDH Hospital, Mumbai. And we, of course, have Dr. Amit Vora. Dr. Amit Vora, sir, also doesn't need any introduction. Very distinguished national figure in electrophysiology and devices. So both of them, the 3 of them together will moderate. And please, sir, please start.
Right. Good evening, everybody. Give me a minute while I share my slides. Right. So I hope my slides are kind of visible to all. Set. Okay. And I'm audible
Yes,
to
sir.
all. Yeah. So this is
Yes, sir.
the topic assigned to me today, an overview of cardiac device associated infections. I will be focusing more on recent advances, a little bit on the basics, but more on recent advances and state of the art. I have no conflicts of interest related to this presentation, and this is roughly what I'll go over in the next 20-25 minutes, the principles of biofilm-related infections, prosthetic valve endocarditis, diagnosis, imaging diagnosis, and treatment, TAVI endocarditis, which is a new entity for many of us, implantable device infections, and a couple of words on coronary stent infections. So the bottom line is we are dealing with a biofilm. Now, what is a biofilm? You can see here that there are many planktonic bacteria, for instance, in the bloodstream. But if they have a surface in the circulation to which they can attach, then they form a colony. And then they multiply within that colony. This could be a heart valve, you get big vegetations, or it could be a device such as a pacemaker. They attach to that device and they multiply within their own colonies. And they kind of exist in a slightly different community compared to free living bacteria. They have intercellular signaling. They can decide when they want to be active, when they don't want to be active based upon various selection pressures like antimicrobial agents. And they have much greater resistance to antimicrobial killing than do bacteria in the bloodstream because they are metabolically less active compared to regular bacteria. And if you have a foreign body anywhere, it's a big problem in terms of antibiotics. Obviously, antibiotics cannot penetrate into or adjacent to a foreign body very well. Activation of neutrophils is defective. And you can see here that if you have Staph aureus with the biofilm, you need to put in more than 100,000 colonies to have, the number of colonies required to cause infection falls by almost 10 power 5. So biofilm is a big headache for us infectious disease clinicians. We can't get our antibiotics in. If we do get them in, many of our antibiotics like the beta-lactams, penicillin, cephalosporins act on the cell wall, which means they may not act upon slowly growing bacteria which don't manufacture peptidoglycan. The bacteria, the organisms are protected. The host doesn't work very well. You have to depend on your antibiotics, and they can often acquire resistance from one to the other. And you have this concept of persister cells, where a few cells persist, and if you stop antibiotic therapy early, they will cause a relapse of infection. That's why these infections require prolonged periods of treatment. And for success, cut it out. As the surgeons say, if in doubt, cut it out. As far as the biofilm goes, if you cut it out, you're doing us a big favor. We start with prosthetic valve endocarditis. Some general principles of treatment. Put these patients in the hospital initially. They embolize, they leak, they rupture their valve, they do bad things to their valve ring. You need a good microbiology lab. That goes without saying. If you don't have one in your center, please outsource your microbiology. It's critical to know what you're treating. You have to pay close attention to what species. Doesn't count if you just say strep. You need to know what species of strep it is. Sensitivities and the exact minimum inhibitory concentration for each drug. You have to look closely for complications, work with your cardiology colleagues, valve ring abscess, embolize, etc. You have to sterilize the blood cultures. Often it's necessary to repeat blood cultures till this is done. And just like today's seminar, you need a multidisciplinary approach, a cardiologist, microbiologist, ID specialist, and the surgeon to fix these infections optimally. Diagnosis in terms of imaging, the traditional tool was the transthoracic echo, which should be done as quickly as possible. But we all know that there is a suboptimal sensitivity. A half to a third of cases are missed. Many reasons, obesity, COPD, etc. However, false positive results are quite uncommon. If you see a clear-cut vegetation, you can generally go by that. And it's very non-invasive. So you can do it repeatedly. But TE is not available. You can conclude based upon a TTE, that's good enough, but you have to proceed to a transesophageal echo if your clinical suspicion is high. And it's a good idea to repeat your transthoracic echo at the end of treatment, just for a future baseline. But what we really lean on our cardiology colleagues is to do a transesophageal echo, which goes much closer to the heart valves through the esophagus, less radio opaque tissue in between. And the sensitivities are clearly higher. But note that this number is just not 100%. There is no 100% test. It gets up there, but not to 100%. And certainly in the context of prosthetic valves and device leads, this is certainly a superior imaging modality as opposed to a native valve endocarditis. You can repeat the test in 7 to 10 days. if you have a high clinical suspicion. And it's very useful, especially for detecting these complications like abscess or a small vegetation. And you may even want to do a TEE in many patients with a prosthetic valve and spondylodiscitis. Chances are high that that discitis came from hematogenous seeding. So lots of uses of echo during diagnosis and treatment of endocarditis. Early on, we do a TEE. Usually, if your TTE does not pick up, you repeat it soon after starting treatment, looking for complications. You can do it intra-op before they go on the pump. If they're going for surgery, it's very useful for identification of complications after they come off the pump. And finally, after you repair and after you complete therapy, you repeat your echoes to establish a new baseline in case they have future issues. What if you can't do a TE for various reasons? Expert is not available, esophageal pathology, patient doesn't want an invasive test. Then you have these newer cardiac modalities, cardiac CT angio. This is a multi-detector. It's a gated ECG gated, synchronized with the ECG. It may pick up even lesions that are missed by TE, especially good for prosthetic valves. And some of the areas where this is a useful test are if you can look at prosthetic valve, perivalvular infections, soft tissue abscesses, aortic root pathology, pseudoaneurysms, fistulas, valve dehiscence. These are all findings that you may pick up on a cardiac angio. TEE will pick up some, cardiac angio will pick up others. And a meta-analysis suggested that this tool actually identified valvular abscesses with higher accuracy. So if you have somebody who's complicated, this is a test you may want to do if you don't have access to TEE. And obviously, you can visualize the coronaries in case there is concomitant coronary artery disease. The other test that has gained importance in recent times is the FDG PET. This is 18-fluorodiglucose FDG. This accumulates in myocardial tissue, so it will blur the whole thing out unless you have a specific preparation protocol, a low carbohydrate, high fat, ketogenic diet, starting about 24 hours earlier, myocardial suppression protocol. And probably this is the way to go in terms of the future. If you can't do a TEE, you do a PET CT. This is a busy slide. Just you need not go through all this. Just tells you that there are numerous studies in the literature which is either as good as a TEE or supplements the diagnosis in patients in whom a TEE is not possible. So certainly if you have a high clinical suspicion of prosthetic valve endocarditis, but you can't do a TEE or your TEE is non-diagnostic, proceed to a PET CT. And these are some of the suggested applications for PET CT. First of all, defining the extent of infection. If it's going down outside the heart, localize where the infection is, detect an abscess, and identify disease outside. For instance, fever of unknown origin. There may be other pathologies or diagnosis other than prosthetic valve endocarditis. And it's also a good negative predictive value. Exclude endocarditis as a source of fever symptoms. So unless things are obvious, blood culture is positive, TE positive, PET CT is increasingly being used in the diagnosis of endocarditis. Well, that's not enough. We may know the patient has endocarditis, but what is causing it? Can't fix it till you know exactly what you're treating. So these patients continuously throw bacteria into their blood. It's a low-grade continuous bacteremia. They typically don't go into septic shock unless they have fulminant infection. So you need to culture a lot of blood. The most important point is the number of cultures, at least 2 blood cultures, and each set should contain 20 ml. So you need to make your patient slightly anemic if you're going to achieve anything through blood culture protocols. Now, if you suspect endocarditis, it's a good idea to pick up the phone and warn your microbiologist. They will look for fastidious bacteria. Typically, they will hold the blood cultures for up to 21 days, although there are studies saying that all these HASEC group organisms, etc., can get picked up early. You need to look for brucella, you need to look for unusual organisms, and you need to repeat the blood cultures if you have staph or candida. These are virulent pathogens for which you have to demonstrate blood culture clearance. Unfortunately, in the real world, we are often stuck with the situation. Culture negative prosthetic valve endocarditis. This is an ID physician's nightmare because you don't know what antibiotic is appropriate. The commonest cause of this is somebody has given previous antibiotics. If it's a sensitive strep, even a course of amoxicillin will sterilize the blood cultures, but obviously not fix the problem. The fastidious organism that causes endocarditis is usually not an issue in the prosthetic valve setting. It is usually more of an issue in the native valve setting. But fungi, other than Candida grows in blood, but other fungi, Aspergillus, etc., are an important consideration. Once again, how do you approach this problem? Stop everything and repeat the blood blood cultures of antibiotics, hold all the cultures for as long as possible, do so-called lysis centrifugation cultures. These lyse macrophages and release bacteria, and these can pick up intracellular organisms, including fungi, mycobacteria. Serologies are available, not readily available in India, but they are available. And very importantly, if your patient goes for surgery, then please analyze the valve, not just conventional histopathology, conventional cultures, but also do 16S, 18S rRNA testing. These are molecular tests to find out what bacteria there is on that valve. Easy to do. Now, there's a very nice statement just recently published a couple of weeks ago, a statement from the AHA on blood culture negative endocarditis, just summarizes the commonest causes are antibiotics before blood culture collection, sometimes a fastidious organism. You use advanced imaging like PET-CT, and if you have that diagnosis, try to use these newer molecular tests, either on the valve or in blood, to make the diagnosis. It's worthwhile reading through this article. Now, there are many non-ID physicians in this audience, and therefore, just a word, what exactly is sequencing? Now, microbes have highly conserved part of their genome. And if you look at bacteria, their ribosomal RNA is highly conserved, that's 16S rRNA, and each bacterium has a specific DNA fingerprint. So if you have a library of known genetic fingerprints, just by analyzing that, you can tell you exactly what bacterium you're dealing with. Fungi have the so-called ITS, which you can do the same thing for. And the differences between PCR, everybody knows from COVID times. PCR, you only can look for one or multiple. In other words, you have to know what you're looking for. But in endocarditis, you don't know what you're looking for, especially when you have culture negative endocarditis. And therefore, you can pick up unlimited number of germs. Unfortunately, this gives false positives as well. Bugs are on the skin, on the equipment may get picked up as well. So some clinical correlation is needed in this situation. What is the role of these newer technologies in endocarditis? Certainly in culture negative endocarditis. Now, in plasma, these tests are not easy to do, but let me tell you, this big outbreak of Mycobacterium chimera, this is a non-tuberculous mycobacterium, post-cardiac surgery, was detected mainly by next-generation sequencing on blood. And this was published, and it's now included in the Duke criteria, as I'll discuss in a minute. And this is really a booming field. Right now, it's very easy to do. This is standard of care. Many centers in India do this on valve tissue. I know that Mumbai has several centers where this is offered. We do it in Chennai as well. But what you're looking at is the so-called shotgun or metagenomic sequencing. This is the so-called carrier's test. That is the trade name for this test. This detects microbial cell-free DNA. In other words, microbes that are outside cells, indicating dead cells or something that is pathogenic rather than non-pathogenic. It can pick up fungi, parasites, even some resistance genes. And therefore, this is really the technology of the future. Now, this is just a study very recently published on endocarditis, and these are all difficult endocarditis. All of them are culture negative, and you can see that the cell-free DNA sequencing was the sole positive test in a third of these patients. So if you find an organism like Brucella or Gonococcus, not a skin contaminant, but that is found on this test, then certainly you can consider this as the cause of your clinical syndrome. Now, unfortunately, we are all in India, not the US, and even the carrier's test is not yet FDA approved. There are many labs in India which unfortunately are not standardized. They don't have proper published data. And so you have to do tests that are available in your part of the country and hope that they do it well. So this is a big problem in India as of now. The Duke endocarditis criteria, I'm sure all of you would be familiar. These have been updated a couple of years back. And importantly, relevant to this lecture, what they have done is they have said that you can take tests like PCR, 16S, 18S, I just spoke about, in situ hybridization on tissue. These are major criteria. In other words, on the heart valve, these are all accepted technologies. And in patients with prior endocarditis, they again recommend these techniques, because if you're treated, then it's very difficult to with antibiotics, you have a problem. The only issue is if you have a past history of endocarditis, DNA, which can be due to dead bacteria, can stick around on that tissue for long periods of time. So that is the only caveat. Always the clinical and histologic evidence of endocarditis, and sometimes you get a single coagulase negative staph on a valve or wire, that they put into the minor criteria, not into the major criteria. So you can see here that organisms, the cultures, the blood cultures remain the mainstay of treatment. But they have also added several newer organisms. Staph lugdunensis, which is coagulase negative on testing, but behaves like Staph aureus. All strep species, except for Pneumococcus, Strep pyogenes, many of these other gram positives are all added. But in the setting of prosthetic material, then all bets are off. Many others that are typically found on the skin, which we just look the other way when we find it outside of the prosthesis cardiac device situation, like Cutibacterium acnes, Corynebacterium. ID physicians don't even ignore these bacteria. Please don't do that in the presence of a foreign body. Certainly that's true with non-tuberculous mycobacteria and Candida as well. The newer cardiac modalities like cardiac CT, once again endorsed, FDG PET CT, once again endorsed in this situation. And you have many different patterns of FDG uptake. The one point is you can't do a PET CT for up to 3 months after your prosthetic valve surgical implant, because that itself will light up to a certain extent. You have to wait for 3 months for it to qualify as a major criterion. And this is a busy slide, but just to tell you that among the minor criterion, if you have early evidence of a hot PET CT, then that is counted as a minor criterion. Right, that is included as a minor criterion. So you can see how these newer tests are finding their way into the clinical diagnosis of endocarditis. The Europeans have put out a similar guideline, but I won't spend much time on this. It's quite similar to the US guideline I spoke about in endorsing these newer tests. So you made your diagnosis of prosthetic valve endocarditis. How are you going to treat these patients? Well, the commonest cause is usually a staph or a strep. Now, staphs, the main treatment difference is you need to treat for 6 weeks minimum, right? There is one study on streptococcal IE where 4 weeks may be enough. But in general, if you have prosthetic valve endocarditis, you're on antibiotics for 6 weeks. Now, the conventional statement was that you add in drugs that are active against biofilm, rifampicin, and something that is synergistic with a beta-lactam for the first 2 weeks, either with Vanco for MR or cloxacillin for MS. However, that is now out. The recent studies just don't support the addition of gentamicin or rifampicin. All these studies here, including this meta-analysis, no benefit of adjunctive therapy. So just give your drug, either vancomycin or cloxacillin. Daptomycin in this situation is a pretty useful drug. It's useful for outpatient antibiotic therapy since it's once a day. It penetrates biofilm well as well. So this is one of my go-to drugs in endocarditis. And surgery no longer the norm. We used to say, you find endocarditis, you cut it out. No, that is not true. Surgery is reserved for conventional surgical indications. Bad heart failure, valve ring abscess, patient about to crash from mechanical issues rather than the infection per se. Now, Candida is a nasty customer whenever it hits your valve, and it's really a double whammy when it hits a prosthetic valve. What you need to use here, I'll just show you the recent Candida guidelines. This is the most recent Candida guideline. And what they say in terms of Candida endocarditis is, if you have a device associated, the first thing is pull the device out and operate. That's operate. Same thing. Pull the device out or operate on the valve. And the therapy of choice is either echinocandin or liposomal amphotericin with flucytosine. Pretty toxic regimen, extremely expensive as well. Treat for a minimum of 6 weeks and then put them on fluconazole for a further period of time, another 6 weeks or so. So this is a difficult infection to treat unless you remove your device or your valve. It's a difficult infection to treat. What about non-tuberculous mycobacterial infections? These are quite topical. The biggest outbreak was this M. chimera outbreak I alluded to after bypass surgery. However, rapidly growing mycobacteria are also seen. This is a nice review from All India Institute, Jodhpur. And you can see who gets these infections, those with prosthetic valves, main risk factors, and up to 60% of cases. And you got to operate without surgery associated with poorer outcomes. So just like Candida, NTM endocarditis, send the patient to the surgeon. They're increasingly putting in these devices in place of surgery for bad valves. And first of all, if you have endocarditis, don't put in TAVI. That just get infected. That's an absolute contraindication to the procedure. If you do develop endocarditis after TAVI, it's really not a whole lot different from regular prosthetic valve endocarditis, except these patients are older and frailer. That's because probably younger patients might go to surgery. These patients are selected out for this procedure. Common etiologic agents, just like prosthetic valve endocarditis, enterococci and streptococci. They are usually blood culture positive, and certainly you probably should use enterococcal prophylaxis when you place them in, because enterococci are a common cause of TAVI endocarditis. Sometimes you can't even find findings on TEE. And in that situation, you may want to consider PET CT. Certainly, if your blood cultures are positive, that's even a poorer prognosis. Infection of cardiac devices is an issue. If it's outside the heart, the usual presentations are pocket site infections or just a bacteremia. Sometimes the leads get infected, and sometimes it proceeds on to infection of the right-sided valves. Diagnosis is quite similar to prosthetic valve endocarditis. Off antibiotics, draw your cultures. If you have visible pus at the pocket site or eroded areas, obviously you can culture that. TEE is mandatory in all these patients, except for children, where you have an easy chest wall to see through. And the management principles are quite similar. Remove the infected device, right? Very difficult to treat with a biofilm in place. Give antibiotics and put a new device in with some interim arrhythmia management that the cardiologist sees fit. So these are all definite indications for removal of the infected CIED. If you have endocarditis or sepsis, if you have a bad pocket infection with bad local inflammatory signs, if you have valvular endocarditis, occult staph bacteremia, if you have a device in you, staph is growing in blood, just put 2 and 2 together, it's coming from that device, out comes the device. And sometimes you may need to do that with gram-negative bacteremia as well. You don't necessarily need to remove the device if it's a very superficial infection. That is something you need to take it in a case-by-case basis. Choice of therapy depends on the organism. Call the friendly ID physician next to you. Usually the choice of therapy is pretty easy. Duration of therapy depends upon what is infected. If it's a pocket site infection, 10 to 14 days. 14 days after a removal for a bloodstream infection, just like a bacteremia. Lead vegetation is less serious than a valve vegetation, so 2 to 4 weeks, and up to 4 to 6 weeks for a valve infection. Sometimes you can't remove the device. They are stuck, technical reasons, or they are so device dependent that they can't take it out. In that situation, they probably need lifelong therapy. For instance, an infected left ventricular device, LVAD, if that gets infected till they get a new transplant, that has to be in. Once again, daptomycin, good drug in this situation. When do you put a new CIED in after removal of the old one? It's just a case by case, how virulent is the organism, etc. Obviously, put it in on the other side. Blood culture should be negative. And if there is bacteremia, generally you wait 14 days. A very nice review article on this subject, just to blow this up. Use one of these newer criteria, the 2023 Duke criteria or an equivalent one. Blood cultures, TEE, FDG, PET, cornerstones of diagnosis. And once you diagnose these, figure out if it's a lead, a valve vegetation, or a bloodstream infection, and manage these patients accordingly. The management of choice, gold standard for cure, is a device extraction. Out it comes. It simplifies everything. Obviously, some kind of interim management of the arrhythmia or pacing is needed as per the cardiologist. Whatever you take out, test. That's an easy test to do sequencing, cultures on, etc. And put in a new device, say valve vegetation, 14 days, and no valve vegetation as early as 72 hours from the first negative blood culture. Sometimes you just can't take it out. This is a bad situation. You give them lots of antibiotics, sometimes chronic antimicrobial suppression, oral antibiotics for life, if you just can't take it out in somebody with a lot of comorbidities, and look for complications. Now, prevention is obviously better than cure, and I told you that these TAVI procedures often land up with enterococcus. So prophylaxis should be with your traditional staphylococcal agent, cefazolin or teicoplanin. And in my center, we had a single dose of gram-negative cover. For example, cefoperazone, sulbactam, especially if the access is through the groin, just for gram-negative coverage. A word on coronary stent infections. This is just a patient we saw a couple of years back, had a coronary procedure, presented with myalgia and weakness. We did a PET CT for FUO, and there the stent lit up along the AV groove. Blood cultures grew pseudomonas, luckily fairly sensitive, did fairly well. And these are pretty rare, 0.1% of cases. These are pretty uncommon. And usually you see Staph aureus or pseudomonas. And these can often kill, because sometimes you can have a stent blowout, coronaries blowout, they get hemopericardium and suddenly die. What are the risk factors in this article? They look at technically difficult placements. You had difficulty doing the procedures, you kept doing it, you repeatedly ballooned. Technically difficult issues are the ones that predispose to stent infection. What do you do for these patients? If it's very early on, within say 10 days of surgery of the procedure, then IV antibiotics. If they present late after 10 days, you usually need to remove the stent. That is mechanically impossible through a endovascular procedure. You may have to send them for bypass. And this is the approach towards this particular problem. First line imaging modalities, echo, as well as PET-CT. Early onset, medical therapy, surgical intervention if it fails. Late onset, out comes the device, probably with through bypass. So this is my last slide. So blood cultures, this is not the time to be stingy on blood cultures. Can't diagnose a device infection unless you culture lots of blood. Use the newer modalities, especially when you can't do a TE for any reason, such as PET-CT. Prosthetic valve endocarditis automatically 6 weeks, but does not automatically require surgery. Many patients do well without surgery. TAVI carries a risk of endocarditis. Got to explain this to patients, especially enterococcal endocarditis. Device infections require device removal, antibiotics, some kind of interim arrhythmia management, and then a new device. Stent infections, very rare, but when they do occur, are devastating. And the best way to get these patients to do well is to cooperate with your colleagues. Thank you very much. I will stop here and I will stop sharing. Okay, thank you.
Thank you, Dr. Gopal Krishnan. It was a fantastic overview of how to deal with infections with prosthetic valves and the cardiac implantable devices. So one of the challenges which we practically face, and you also mentioned it, is, we have a pacemaker-related infection, and this device needs to come out, and we remove the device. And some of these patients are dependent on the pacemaker, so they are on a temporary pacing wire of some sort. And as you said, that when to put in the new device becomes a clinical challenge, and often we have to take the decision earlier than later. And my question was this, that you rightly said that you wait for a repeat blood culture being negative, but often practically we find that these patients are already on antibiotics, and we often, even if we have removed the device and sent for microbiology, often we don't grow anything particular in a short period of time. There is no guidance. How early in such a situation, when there is no clinical evidence of bacteremia or sepsis, do you think a new device can be implanted on the other side?
Yeah, so if you have positive blood cultures earlier, that is before your device came out, then it becomes very easy. Guidelines are clear. Just bacteremia, 2 weeks. If you have wire or lead endocarditis, 2 to 4 weeks. If you have a true right-sided, say tricuspid endocarditis, alongside the wires as they go into the heart, it becomes 4 to 6 weeks. So that is when you can put your new device in. That is what the guidelines say. So in a situation where your first cultures are negative, you're dealing with a prosthetic valve or a device endocarditis, which is culture negative de novo. What you need to do is to analyze the extracted device to the best of your possibilities. Try to do sequencing, try to do specific cultures, want the microbiologist beforehand that you're desperately looking for organism, look for fungus, etc., and try to make a diagnosis and treat accordingly. There, obviously, repeat blood cultures will be negative. They were negative in the first place, and you take a call depending upon the anatomy, whether the valves only had vegetations, whether the wires had vegetations, pocket site infection, etc., and go ahead. And sometimes you just have to keep the patient on antibiotics, go ahead and put your device in. As you said, they can't manage too long without a temporary device.
Yeah.
I think you
I
covered
think,
Vinay
yeah,
has.
please go ahead.
Yeah, so you covered most of the aspects. Now, when it comes to CIED, the challenge, of course, is to remove the device. I mean, it happens so often. One, due to economic cost issue, it's a significant burden to the patient. I think getting the device out, putting it in. So I think a lot of trials now which show where an antibiotic envelope which can be used as part of CIED, which reduces the burden of infection by 40%, or where the device cannot be removed, a long-term local infiltration of antibiotic. All these have been tried. Any experience from your end, sir? I mean, but these are quite few studies which have happened, but not part of the guidelines though. Anything in terms of local infiltration of antibiotics or antibiotic envelope when CID is made use of to reduce the risk of infection. So
yeah, I am not aware of anything that envelopes or anything to reduce. If the electrophysiologist says they cannot remove the device, then I plan to treat for long periods of time. It's like a chronic suppressive therapy. If you have an oral option, probably after 6 weeks, try to shift to that oral option and assume that they're going to be infected for life. It's a general principle when you do suppressive therapy that after, with a biofilm in place, after 1 year or so, you attempt to either to reduce your dose or to stop the drug. That's exactly what I do, similar to a prosthetic joint. But it's a bad situation.
If I can add a point here, the antibiotic pouches are actually contraindicated when somebody has got an active infection. It's mainly to prevent infection. So once you have extracted the device and you are planning to contemplate to implant the device from the other side, so you're going to wait for 72 hours with 3 negative blood cultures. You can use the Tyrex pouch, which is like a bio sort of absorbable material which constantly releases rifampicin and minocycline over the next 6 weeks period. So that can be used, but there is a risk assessment criteria even in sort of patients who are undergoing a device implantation to start with. So there is a scoring system. So somebody with a renal dysfunction who's on hemodialysis, or patients with previous infective endocarditis, so forth and so on, these Tyrex pouches can be used. So it's mainly for a preventive purpose rather than when somebody has got an active infection. The only solution when somebody has got an active infection is that to remove the device. Even in patients who are actually dependent, you can have a semi-permanent system where you can put a permanent lead through the internal jugular, screw it to the septum, and then stick the device on the neck and treat them like you treat the bacterial endocarditis, and then go on to re-implant the device from a contralateral.
I think it's very important to kind of understand as far as these pacemaker and CID infection is concerned, that once you have an infection, the entire hardware needs to be removed. I know that removal of the hardware is always a challenge, but it is almost certain that if the entire hardware, the leads, they may be very chronic and long-standing leads, but unless and until you have removed all the hardware, the chance of infection, I mean, systemic infection you may take care of, the infective endocarditis you may take care of, but the local infection at the pocket site is just not going to go away if you have not removed the leads. And of course, if you have a infective endocarditis of the leads and then surgical removal may have to be considered. But somehow or the other, I think it is a must that we have to make all our efforts to remove all the hardware. Only then the infection clears off. And that is where I think, we see so many times when there is a pocket infection, some stuff, the leads are old. In many areas, many places, they don't remove the leads. They just cut the leads, leave it behind. And that does not solve the problem. And it becomes worse when they get referred to a tertiary center, that the leads which are cut now are not usable in terms of extraction tools to remove these devices. So I think in short, pacemaker and CID related infections, be it pocket infection or be it vegetation or infection on the lead, removal is the key to solve the problem. And yes, semi-permanent pacing has become a very, a new novel technique which has helped us to tide over a longer period of time in terms of giving proper antibiotic course before we do a new implant on the other side.
Can I have a question, Dr. Amit Sanghia, sir? So I just one question is that, so you have extracted everything and the patient is affording. And can we use a leadless pacemaker in this situation? And what is the time frame? So do we wait, for like 10, 15 days before we put in a leadless pacemaker? Can it be done a little earlier if there was local pocket site infection and you've removed everything? So.
Yeah, so as I said, the pocket site infections are the easiest because that is totally local and you removed all the hardware there. If you have a bacteremia, roughly it's about 14 days. If you have a lead endocarditis, the duration of therapy is about 2 to 4 weeks. So minimum 2 weeks you have to wait. If it's gone to the valve, then it's 4 to 6 weeks. So I would wait even longer. So that's a rough guide when you can put it.
So Amit, the pacemakers are generally, single chamber pacemaker as yet. So it is a very limited utility, but you have many patients with dual chamber pacemakers, you have ICDs, you have biventricular pacing. So just a leadless pacemaker will work in small group of patients, but not for the majority.
So there are a couple of questions from the audience, if you can take them. One question, of course, was the duration of antibiotic therapy in stent infections. So if stent infections are there, whether depending upon whether you're sending the patient for surgery or not sending, how long should you treat with antibiotics? That is one question. So could you please take that?
Yeah, a long time till the stents are out. Usually my colleagues just can't remove stents once they are infected. Usually you give them a trial of medical therapy, especially if it comes within the first 1 month after the procedure. But if that doesn't work, if they're bacteremic, then they need to have bypass surgery. At that point, the stents are removed. Duration of antibiotics, definitely till the stent is removed, and then some more. And if you can't remove it, then long term. If you have oral options, great. And you can't remove, patient cannot have the foreign body removed long term, months.
Right. Thanks for that. And sir, there's a small question on whether procalcitonin can be used in these device infection patients for diagnosing and monitoring treatment.
No, procalcitonin has too many caveats. It's best studied in sepsis, best to avoid this in this situation.
One more question was, I think you had this in your slide, but just for reiteration, for prophylaxis, antibiotic prophylaxis before pacemaker insertion or device insertion, what should be the regimen?
The mandatory drug is something that covers staphylococcus, cefazolin. In my center, we tend to use teicoplanin and cefoperazone sulbactam. Remember, only one dose, not prolonged therapy. One dose will give you 4 to 6 hours. These are not long procedures.
We have other panelists also if they want to chip in.
William, can I add?
Please.
Gopal Krishnan sir, it's an honor and a privilege to hear your absolutely stupendous talk on inaugural talk this evening. Sir, we had a series of six stent infections in the last 7 years. We lost one of them, but after we lost the second case, we realized that probably early surgery is the best option. And then Kaushal is here, and he operated all those patients. One was operated by Dr. Nafde, rest 5 were operated by Kaushal. We lost one, but rest all have done well with a decision, sort of a team decision to get them early, get the stent, infected stent out, and the entire abscess cavity debrided, and then graft the artery which has been the stent of which had been blocked off. And of course, they needed prolonged antibiotic therapy. Even after that, average duration was around 6 weeks post surgery. But what I wanted to ask you out of this was, what we grew in blood culture was entirely different than what we grew in tissue culture in 5 out of those 6 cases. Completely different. Completely means completely different, sir. So that was one very unusual that I always wanted to ask someone. So now that you are the father of IE in this country, so
no, so that's quite unusual. Usually, what you grow in the blood, multiple sets of cultures, if they're all positive, you should find the same thing on the device. Sometimes there may be more organisms on the device because only a subset of them may get into the bloodstream. So simple, cover all that you find, what's in the blood and on the device. That's all.
Yes, sir. Yes, sir. And sir, one more thing about the prevention, about not the antibiotic cover, but after one study, I don't remember which one offhand, but it was a randomized study done for the chlorhexidine pocket wash at the end of the procedure. That we have been doing quite regularly, chlorhexidine pocket wash. And what is your comment on that, sir?
Yeah, local techniques are always in addition to systemic antibiotics. To be frank, it is the experience and skill of the placer, of the electrophysiologist. If they are good, usually infection doesn't happen. Very simple. If they are inexperienced or don't do many procedures, then infection is a risk.
Yes. Thank you, sir. Thank you very much.
Other panel members, if somebody wants to chip in, we have 2 minutes more, 1 or 2 minutes more. Otherwise, we can go to the next.
Just one thing. So the PADIT trial actually said that local infiltration of antibiotics has no use. So we have a small trial data which says that only giving one antibiotic dose previous should be enough. So they did, I think they had like 5,000 patients, and they initially gave an intravenous antibiotic like cefazolin or vancomycin. And in the extended antibiotic arm, they used cefazolin plus vancomycin. And if the patient was allergic to beta-lactams, then only vancomycin. Plus, they did use pocket irrigation with bacitracin, and then they gave oral antibiotics, either cephalexin or cefadroxil, and they found that there was no difference in. So actually, the trial data says there is no. I think we all use a little local infiltration of antibiotics because we are too scared of not doing it. But I don't know, Dr. Amit Vora sir and all, they have a lot of experience. So what is their practice?
Yes, local infiltration of antibiotic is actually, yes, not scientifically proven, but it's an age-old technique. So many of us continue doing it, especially in high risk, multi-system organ problem patients. Infiltrating local gentamicin is is the commonest thing which we use. But no, I guess it's not something which there is any backing to such a practice, and I think it's best avoided.
I think
have
one quick comment from Kane sir, and then we can go ahead.
Amit, I wanted to ask you only. Anybody can answer this. What is your antibiotic protocol when you put a pacemaker? Forget about the guidelines. I'm not interested in the guidelines. What do you do in your patient? One shot of antibiotic, is that all that you do?
No.
Let's talk what we practically do.
My practice is 1 hour before the procedure, the antibiotic goes, and then I do continue intravenous antibiotics for 48 hours. Now, this is my practice. Now, as has been said and scientifically proven, you need probably IV antibiotics for 1 day. Maybe one dose prior is must, but post procedure, many centers and many recommendations are there. We do tend to give prolonged antibiotics, which is not required at all. And yes, as was said, that depending on the type of procedure and the comorbidities, broad spectrum antibiotic, which covers gram positive and gram negative, is what we give.
And there is another thing, sir, which I wanted to ask you. In municipal hospitals or general hospitals, we think the immune status of the patients is poor, so they are more likely to get infection. And we do see infections more when we were working in public hospitals. There may be multiple reasons, but do they qualify for a longer duration of antibiotics?
Now, as per the literature, in fact, this has nothing to do with pacemaker insertion. Any surgery, anywhere on the body, let it be bypass, let it be neurosurgery, the antibiotics work only from the time of skin incision to the time of skin closure. So that is the principle behind giving one dose, or at the most, if it's a long surgery, 24 hours of antibiotics. So the immunity has nothing to do with it. It is the breach of surgical protocol when the skin is open. A lot of tissue handling, messy blood, or an unsterile operating room where skin scruff falls into the surgical site. So those are the factors that cause infection. That may be what is going on in municipal hospitals rather than their immunity.
Obviously,
So after the skin is closed, there's no role for antibiotics.
One more thing which I want to stress here, sir, because I feel we have to popularize how to be clean when you do the surgeries or the pacemakers. How should you sterilize your hands? What should be the protocol? I don't know whether it is standardized in all the cath labs, whether the nurses are aware of what the doctors are doing. So there are so many things involved in this.
It's a regular surgical procedure. So it's just like operating, except that you do it in a cath lab. So everything from preparation, giving the antibiotics before, using chlorhexidine disinfection, to gloving, to scrubbing, exactly like a surgeon.
That's very important for everybody to realize this. Yeah. Thank you very much. Milind, go ahead.
Yeah, so we have another 10 minutes of discussion time at the end. So I think we can move on. Dr. Parth, can you please start sharing your slides? So we have two case presentations. From one is Dr. Parth from Dr. Ponde's team at Hinduja. And then there will be a case by Dr. Neha Gupta. So for the first session, Dr. Ajay Mahajan sir from cardiology side will be moderating. We all know sir very well. He's a professor and head of department of cardiology at GSMC and KIM Hospital, Mumbai. and a very all-round, multifaceted, distinguished cardiologist. And we'll be glad to have his moderation and expert comments. And Dr. Neha, if you could please introduce Dr. Bharat.
Yeah, and this session will also be moderated by Dr. Bharat Purandre. He is Senior Infectious Diseases Physician in Dinanath Mangeshkar Hospital, Pune, and he has also done his infectious diseases earlier from Hinduja.
Okay, Dr. Parth, please take over. Dr. Parth is there?
He's there.
Yeah, Dr. Parth, please, you can share your slides.
Well, the PPT is not getting shared, sir.
No, you have to share. Do you want me to share from my side?
Yes, sir. Yes, sir. Please, sir.
Huh?
Yes, sir.
Okay.
Dr. Parth, you're not very audible also.
Can you hear me, sir? Hello?
No, little
Yeah.
voice is little muffled, Parth.
Now, sir?
Yeah. Can you see this?
Yeah.
Yes.
Okay. So, Parth, you can go ahead.
Yes, sir.
I had kept as a backup.
Okay. So, my name is Dr. Parth. Everyone, the topic is pacemaker. So, we had a patient of 58 years old male in case of so in view of complete heart block, he underwent permanent pacemaker implantation in 1998 and subsequent generator changes in 2004 and 2012. He was admitted on 11th chest 1 month prior, and he
We are
came
not able to. The Parth, we are not able to hear you clearly. Voice is cracking. Is your internet connection okay? Have you laptop from mobile or what? Or what?
Yes, sir. I'm from the mobile, sir.
No, but then the mobile connection is not good or whatever. I don't know.
Mobile. Hello? Hello?
Little cracked voice. You can go to little different place and see whether the mobile signal is good.
So otherwise, sir, could you go ahead
Hello?
till he
Can you
gets
hear
his
me, sir?
Yeah, I can hear you, but just okay. Start, Parth. Let us see how is your voice.
Yes,
I mean, audio.
Hello? Can you hear me, sir?
Yes, we can hear you, Dr. Parth.
Okay, go ahead.
Hello? Of an exposed pacemaker lead that the patient had come with. Next. So he was trying to have Lennox, Zolid, and Ferropenem empirically by a local doctor, which was given for 15 to 20 days. He came to Hinduja Hospital on 1st of February 2021. The 2D echo showed an LVEF of 55%. There was mobile pedunculated vegetation around 2.1.8 centimeter attached to the tricuspid leaflet in the RA and a small vegetation in the RV. So we have the video recording of the
I can't hear you, Parth, again.
vegetation.
Sir, I think in the interest of time and clarity, would it be possible for you to take over, sir? When Parth gets a better range, he can come
Parth
back.
gets a, please get a better range, beta. Okay, I'll just go back and see this. This is a patient, 58-year-old male, hypertensive, complete heart block. He's a marine engineer.
Next.
Permanent pacemaker by on 2nd of
Hello,
April.
can you hear me, sir?
No, again, the voice is cracking, Parth. There is no clarity to your voice. Go to some other place where the mobile signal is excellent.
Dr. Parth, you just stop at the moment. When you reach a range, tell us. Dr. Ponde sir is presenting now. Please let him present.
So, first and
please.
second generator changes occurred on 27th of October 2004 and later on in 12. He had history of blunt trauma to the chest a month ago, and then he called me saying that, sir, I am getting some pain and discharge from the wound. I said, come over, get yourself admitted, let us visual and let us understand what it is. But he refused, and he kept on talking to local doctors, and local doctors gave him Linox and Ferroname for a period of 15 to 20 days. And when the wound was not healing at all, he came and he showed this was the two pictures which I took in my OPD. This was the day 1 picture, and this was the day 3 picture. So the lead was completely extravasated. The 2D echo, as you showed, as clearly showed a mobile vegetation on the tricuspid valve. However, we could not see anything directly on the lead, but there was a significant tricuspid regurgitation. The vegetation measured almost 1.5 to 1 centimeter in size. And now you can see clearly here, this is the atrial lead, the J of the atrial lead. On the J of the atrial lead, you can see a pedunculated vegetation and another on the septal leaflet of the tricuspid valve, if you can see their mobile downs. This was a transthoracic echo, of course. Now, the risk of infected device retentions are very, very high. As Sir just said in his first talk, the stupendous talk of today evening, you will have a very high short-term mortality risk because there will be uncontrolled source of infection, and the infection might have already formed a biofilm. Longer course of antimicrobial therapy will be required, and of course, adverse effects from chronic oral antimicrobial therapies are needless to say. So there is a very high chance that this patient will require uh, uh, extraction of the entire device. So I contacted Dr. Amia. Amia said surgical lead extraction will be required because there is a very clear evidence that these are involved now. So ID reference was given. They said hold antibiotics for 5 days before surgery and send the specimen for culture and sensitivity reports and histopath. So what we did was this. Sorry. Infected pacemaker removal and lead extraction with temporary epicardial pacemaker lead insertion done by Dr. Kaushal Pandey, who is very much here. You will remember this case, patients and the patient very vividly. On 4th of February 2021, specimen was sent for culture and sensitivity reports. Patient was shifted to ICU on inotropic support in mechanical ventilation. Antibiotics started meropenem, vancomycin, and caspofungin as empirical broad spectrum antimicrobial cover because all blood cultures were negative. Then on 6th of February, a culture which was drawn just on the previous night of surgery grew GPCs. This was sent just around 12 hours before surgery. So dose of vancomycin was increased to reach the optimum tough levels. On 7th of February, inotropes doses came down, but vegetations and tissue culture grew Staph aureus, MSSA. Antibiotics now changed to vancomycin and clox by the ID team. And this is the literature frequency of the organisms. From 816 consecutive patients who underwent lead extraction or removal for device infections at the Cleveland Clinic. And as you can see here, MS cons and MR cons are the commonest. MSSA the second commonest. And of course, MRSA and MSSA were almost equal proportion. Post-op course on 8th, that is 4 days later, he had blurring of vision. Ophthalmology reference was taken, CT brain and head neck angio was done. which was normal. 9th of February, pacemaker lead culture grew methicillin resistant coagulase negative staph hemolyticus, MR-cons. Antibiotics were changed by the ID team to vancomycin, cefazolin, and rifampicin. Fluoxetine was changed to cefazolin as there was suspected CNS septic embolic infarct, and rifampicin was started to prevent biofilm formation on the foreign body. This is questionable, but we'll discuss that later. And this was the culture I just showed you. The staph aureus is the first culture which was pre-surgical drawn grew, and this is the second culture. And as you can see here, uh, staph hemolyticus grew in this pacemaker box and pacemaker lead culture. This was a scanty growth, but however significant. On 10th of February, he had acute kidney injury, increase in the creatinine. Vancomycin, cefazolin was stopped, and rifampicin and Vapto was continued. On 11th of February, patient was on tapering doses of inotropes. 12th of February, he had complete recovery of vision with no neurodeficit. Rifampicin and vancomycin were continued. On 14th of Feb, 2 episodes of fever spikes, repeat blood cultures were sent and meropenem was started for gram-negative broad coverage by the ID team. Thus, the regimen now was meropenem, rifampicin, daptomycin. Uh, on 15th of February, he had swelling of the left upper limb and right forearm swelling as well. Venous Doppler showed basilic vein and axillary vein thrombosis. And surprisingly, there was right radial artery thrombosis, probably from the right radial artery line which was there. Unfractionated heparin was started because of high creatinine. Here, persistent fever spikes, but blood culture showed no growth at all. 17th of Feb, rifampicin was stopped by the ID team as 7 days were completed. Linezolid was started as suspected. There was suspected cellulitis of the right upper limb. Meropenem, daptomycin, linezolid was continued. AKI was persistent. On 20th of February, thankfully, he had the last fever spike and later on became afebrile. Meropenem, linezolid was stopped as symptoms were better and daptomycin was continued. Daptomycin finally was given for a long term. Blood culture on uh, further showed no significant growth. 23rd of Feb, the AKI had resolved. 22nd of Feb, we did a TT which showed no vegetation, and a transesophageal was also performed. Unfortunately, we couldn't get the films of that, but showed one residual small vegetation on the septal leaflet of the tricuspid valve with grade 2 TR, nothing significant. Surgical epicardial, and then, of course, Dr. Kaushal Pandey only performed surgical epicardial permanent pacemaker under general anesthesia, and VVIR St. Jude was MRI compatible was implanted. 25th, we did a CT venogram which showed SVC syndrome, but moderate obstruction, and we sent him home on warfarin. Daptomycin was continued 3 weeks post-discharge, and total of 6 weeks he completed on 17th of March. 2D echo showed LV of 45%, chronic healed vegetation on the septal leaflet of tricuspid valve, and everything was normal. The risk factors for implantable device infections are younger age. This is a padded score, classic padded score. Multiple comorbid conditions, including particularly cardiac devices implanted at the same prior revision. Suppose the revision procedure, more the risk. Complex or long procedure, more the risk. In post-operative hematoma, higher the risk. I will not go through this. This is for discussion, and I stop here for the further discussion. Thank you. Kaushal is also here.
Requesting the
Good.
moderators.
Thanks, Kaushal.
Requesting the moderators to please carry on the discussion.
Lot of learning from this particular case. So this just one question: is all precipitated because of external trauma, or it is a pre-existing infection at the second implantation time, which got detected after trauma?
No. I think second implant was far much. It was remote. It was very, very remote. This was just one of those cases where you just don't know the cause, whether blunt trauma itself or whether after blunt trauma he kept on doing some unsterile kind of dressings. I have no idea, but I don't think so. Parth, what do you think it is? It was remote, no? The second generator change was remote from the point of infection. Am I correct, Parth?
Yes, sir. Yes, sir.
It was remote. Yes.
Bharat, your comments?
Have
So,
any
so,
comments?
so
It's
does
ask
this
Dr.
blood
Kaushal whether he has any comments.
one question? Does this blood trauma, which are basically related to the skin, so the
Yes.
skin contamination is one of the most common cause. So, does that particularly lead to the infective endocarditis and that to the healed leads which are implanted 20 years back?
I have no idea, Ajay. I mean, your guess is as good as mine. I simply don't know. I asked this question to our ID team as well. They said, "Sir, we also don't know how this happened after such a long time after the second generator change." Uh, but Parth, first 6 days he had hectic fever. Am I correct, Parth?
Yes, sir.
First 6 days.
Yes, sir.
Yeah. And first, do you in your this thing the culture the culture report the tissue culture were done only one or twice because I think it was two. You showed only one, right? The lead culture was one or two.
No, lead culture was one and vegetation culture was other, sir.
Acha, acha, okay.
Dr. Bharat, you are our second moderator. Any comments?
It's an excellently managed case. That's what I can say, Milind, because this patient had two organisms and both had to be treated separately. And ultimately, this we have seen many times that vancomycin after 2 to 3 weeks starts causing acute kidney injury. So although
Yeah.
all guidelines are saying that vancomycin should be given, vancomycin is not nephrotoxic. In reality, we are finding that once we cross 2 weeks of vancomycin, there is a chance of nephrotoxicity. And if you combine vancomycin with beta lactams, then again there will be a chance of further added nephrotoxicity. So those studies have been there in Camera 1 and Camera 2 trials. But this case was ultimately managed on daptomycin, which is sort of possible to cover both the coagulase negative staphylococcus which they got and the MSSA that they got. So, although there is emerging data about daptomycin in CID infections, the guidelines are still very skeptical about use of daptomycin in CID infections. But in practice, over last 10 years, we have been using high dose daptomycin for multiple infections, including some complicated infections. It does have a role when the other antibodies do not work. So, but it's a team effort pulled out by this Dr. Pandey sir, Dr. Ponde sir, all the cardiology team, because everybody has acted, and that's why this young patient could have been saved. Otherwise, it would have a mortal infection. And actually, we have lost many patients because of not doing surgical procedure at the right point of time, not removing the entire circuit, and just removing the generator battery, and resistance sometimes from the cardiologist and even cardiac surgeons in handling cases which have been operated outside. So that is one point I wanted to stress here, that even if a patient is operated outside or some fallacies have been done in outside management, when patient comes to us, we'll have to all work together and get that patient out. We cannot say that it was done from by outside person and we are not going to sort of
Yeah.
do our job.
Milind,
And
Milind, I must say, just one small line that I must say that our ID team, the team of Dr. Aisha Sunawala and Umang Agarwal has been brilliant in managing this case. Our microbiology lab, I don't have any words to say. Camila Rodriguez and Anjali, they are absolutely I would say they are clinical microbiologists. You know, they come to the wards to see the patient every day, what is happening, what antibiotic will change, why it has been changed, what doses have been used, and so on and so forth. And of course, to add to the list, Parth, that he was that time the junior most the DNB student, but he has passionately looked after this patient right from the second day till his discharge and even follow up. So I congratulate Parth for that also. And last but not the least is Dr. Kaushal Pandey, who is extremely cooperative and at the same time judiciously aggressive, I would say, to treat his infected. All his 6, 10 cases I showed. And this case also, he said, now we cannot wait 2 to 3 weeks for because the contralateral side was not an option because the valve was infected.
prophylaxis prior to surgery?
Sorry?
Can we use a daptomycin as a one drug just prior to each and every pacemaker 1 hour prior to the procedure? That is a mandatory drug for the treatment of prevention of pacemaker infection.
No. See, our microbiology team, and I don't cross their word even by one word. When Camila says 1 dose of tifazoline 1 hour before, 2 doses, 6 hours and 12 hours later, that's it. And then if the patient is high risk, like chronic renal failure or something, then one single dose intra procedure for gram negative cover. That's it. So 3 doses of tifazoline and 1 dose of gram negative in high risk patients with a padded score of 3 or more. So that is what we have been doing. And I think we have had no problems. This one patient, I don't know how. Sorry about, I just don't know how he had.
We are quite running behind schedule, but
Thank
Dr.
you,
Ashish
sorry.
Nabar, very senior electrophysiologist, has put a question, so we need to answer that. Could surgical have been done during the first surgery? That is what sir is asking, Dr. Nabar, sir.
Surgical would have been done?
Could it have been done during the first surgery? That is what he has written.
No, our ID team said whatever you want to do, next implant, whether it is epicardial or whatever, you must do after 72 hours after the first sterile blood culture. So that is what we waited for. So I think
you very much,
all
sir.
in all, thank you.
Thank you. Excellent case, sir, and your team.
I'm sorry,
And
Parth,
Dr.
audio was he was so interested in presenting this case, but audio was a problem. I'm really sorry about that. Thank you.
Problem, but still, sir, it was a wonderful thing. And Dr. Neha, please, the second case. Could you please take?
My presentation after the call for me.
Okay, so the second case is going to be presented by Dr. Neha Gupta, and Dr. Suresh Kumar and Dr. Sanjeev Karkekar are the moderators. So, please.
Yeah, sure. So, is this visible now? Is it visible?
Yes, ma'am.
Yeah, please go ahead. Please.
Yeah, sure. Okay. Thank you so much. And I'm going to be presenting a case on the cardiac device infections. And it's really a pleasure and honor to be part of this. And thank you to Dr. Ponde sir, even recently, for giving me advice on one of the patients. So I'll begin with this acknowledgement to my mentors, Dr. Rajiv Soman sir and Dr. Kamala Rodriguez, for empowering us always. We know that the developing world has an unusual combination of factors which are responsible for the intravascular stent-related infective endocarditis and endarthritis. And I'm going to highlight this today with this 51-year-old gentleman who had undergone CTCA of LAD, and then 4 weeks later, he developed fever. Subsequently, he also had cough and skin nodules. The coronary angiography was done, which showed there is coronary blockage. And here we can see this, that the stent was broken and was lying in the LAD aneurysm. And I remember Dr. Ponde sir showing us this over there. So the blood cultures were positive for AFP. They were identified as M. abscesses, and infectious diseases opinion was sought at this point. Now, this happens to be almost 18 months after the initial onset of symptoms, which was fever. Now, all this was happening elsewhere. So this patient was initiated on clarithromycin, moxifloxacin, and linezolid, and the plan was to do the stent removal. However, the patient died before the surgery could be performed. Another patient, a 56-year-old gentleman who was treated elsewhere, PTCA of LAD was done. Fever occurred after 1 month and blood cultures were positive. For NTM, he also had a vegetation at the mitral valve and was then subsequently treated with MDR and antibiotics, imipenem, ciprofloxacin, and abincacin, which was given for 3 months. He improved and was discharged. But 3 months later, he presented to us with fever, congestive cardiac failure, features, anemia, recurrent NTM bacteremia, and there was again vegetation at the mitral valve. So it was prosthetic valve which got infected, and there was a new vegetation at the aortic valve. The AFB culture was positive. And here, it was identified as the Mycobacterium chiloni, which was susceptible to moxi, clarithromycin, and imipenem, and notably the antibiotics or the anti-TB drugs, which are used for treating the MTB, are resistant. So the coronary angiography was performed, which showed that the LAD was blocked, and the patient was treated with clarithromycin, amikacin, imipenem, and moxifloxacin. CABG was performed. MVR, AVR was done 7 days later. However, the stent could not be removed because it was thought to be too risky to be removed with the surgery. The patient developed stroke immediately post-operatively. The valve, which was excised, showed granulomas with occasional AFE, and the valve culture, as well as the 3 weeks post-operative blood culture, remained to be positive for the NTM. Now, this is persistent mycobacteremia, which happened because probably the stent could not be removed here. So like any other infectious diseases, NTM infection also can present with different phases, as we can see here. And as NTM bacteremia is associated with very high mortality, it's important to suspect early. So the major clinical syndromes definitely are pulmonary and extrapulmonary. But if a patient has undergone a cardiac device procedure, then we must also consider NTM infections, and usually it's caused by M. abscessus, fortuitum, or chiloni. Now, this is our experience with intravascular stent-related endocarditis due to rapidly growing mycobacteria, which was published almost a decade back as a new problem, emerging problem in the developing world. And we had like 5 cases of RGM bacteremia. Important to notice that the temporal onset of symptoms was 4 to 8 weeks following the PTCA. Now, this is a little later as compared to if suppose it's happening because of procedure-related Staph aureus, GNB, Pseudomonas, or Burkholderia. They will have a more acute onset. Now, when should we suspect? So, if a patient is having fever following the index procedure, and especially if suppose it's happening 1 to 2 months later, fever with children riders, anorexia, weight loss, anemia, PCF, skin nodules, clinic abscesses, infective endocarditis, we should also consider RGM mycobacteremia. And cardiovascular device infections, in fact, LVAD procedures, or in fact, CIED infections with rapidly growing mycobacteria have also been published. So we have, this was our experience earlier in Medanta. Now I'm in Fortis. There were few cases of RGM or NTM mycobacteremia which were seen. Now, how do we diagnose? As Dr. Ram Gopal Krishnan has elaborated it. So it's basically a combination of echo, angiography, radiology, FDG PET, microbiology, importance of blood cultures as well as the molecular assays, and a proper histopathology which will help in arriving at the diagnosis. It's important to send blood cultures in the appropriate volumes. So at least 3 sets, half an hour apart, or maybe 2 sets within 24 hours should be sent. And a set is aerobic and anaerobic blood culture. If you're suspecting NTM, then microathletic blood cultures will help in better isolation of the RGM infections. Now, the ones which are related to the cardiac device infections, the rapidly growing mycobacteria, although they are termed as rapidly growing, but they still take a longer time to grow and may take up till 5 to 7 days for growth. So that is why it's important to keep the cultures for prolonged incubation. And if the blood culture flags positive, then a Gram stain will identify them as Gram-positive beaded rods, which will raise the suspicion. So here the skill of the microbiologist becomes very, very important. And then it's the AFE, which is positive. Now they can be identified quickly with the help of this NPT64 antigen, whether it's the NTM infection. And nowadays, we can also do MALDI-TOF for the ID as well. And NTM PCR is also available, but it cannot be really done from the blood. We can perhaps also go for the new molecular assays like the metagenomic NGS, which can help in the identification. Management includes a good surgical source control, which is the mainstay, removal of the entire foreign body, infected stent, vegetation, and effective antimicrobial therapy. Remember, the anti-TB drugs do not work for the rapidly growing mycobacterial infection. So what works? NTM is not far behind in resistance, and this was presented in FISCON in Chennai. We have very limited treatment options which are related to amikacin, linezolid, and clarithromycin. And this is one of the recent data again from the Department of Infectious Diseases and Microbiology at Hinduja Hospital, Dr. Irfana and Dr. Aisha Sunawala, which again elaborates that it's amikacin, linezolid, clarithromycin are the major treatment options. In few cases, we may be able to use imipenem as well as ciprofloxacin. Now, when we talk about differential susceptibility of the various NTM infections, there is increased resistance which is seen among the M. abscesses and M. chelonae when it comes to moxifloxacin and ciprofloxacin. Fortutum may be susceptible, and here in this case, fluoroquinolones may be used, but the mainstay are the three drugs to which the NTM is susceptible. Amikacin, which is combined with linezolid and clarithromycin. Alternatives like clofazimine can be used if there is intolerance, and bedaquiline is also can also be considered. Now, treatment duration. It will depend upon the site of infection and the valvular involvement. So it can range from months. If there is valve which is involved, then at least 1 year. And if the stent is not removed, which is then the infection is like it has a very bad prognosis, but there it is probably going to be a lifelong chronic suppressive therapy. So the treatment has to be individualized based on the tolerability of the drugs. Prevention, infection control for RVM is very, very important because it's a waterborne organism and is resistant to chlorine and aldehyde-based disinfectants. And it is probably the jet cleaning of the instruments and inappropriate disinfection practices with 2.4% glutaraldehyde, which may be the reason behind this infection. To summarize, cardiovascular device infections due to RGM is life-threatening entity, and early suspicion, optimized management, and infection control measures for prevention is of great importance. And it is the collaboration between infectious diseases, cardiothoracic surgeons, cardiologists, microbiologists, radiologists, which will help in managing such complex infections. Thank you so much.
Thank you, Dr. Neha, for a very interesting case. And I request the two moderators, Dr. Suresh Kumar and Dr. Sanjeev Kakekar, to please take over. We have 5 minutes discussion time.
Neha, nice presentation of your information. I just want to understand, is there any study whether the stent and material used for during angioplasty, whether it was new NY or OX, whether that is a reason for getting infection with the stents or some other reasons are there? And second question was, does it says that with this episode, because the stent infection is dangerous thing, whether one should advise antibiotic like pacemaker for all the angioplasty also?
Your first question, whether it's any particular material which is being used.
Is what he means is, Dr. Neha, what he meant is, does reused material play a role? NY and OX, by that he means, does reused material play a role in these infections? Because often they are sterilized with Sidex nowadays, you know.
Absolutely. So it is the reuse of angioplasty balloons where probably the infection control practice may not be appropriate with the use of Sidex. Sidex, the NTM infections are resistant to Sidex, so they may thrive in it. And when these balloon angioplasties, they are again reused, that will predispose to infections. And what was the second question?
Antibiotic prophylaxis, should it be routine like in the case of devices for angioplasty?
Yes, absolutely. The antibiotic prophylaxis is going to be the same. And of course, it will vary from center to center, like we have just seen in the discussion.
Neha, presently, we do not use antibiotic for all the angioplasty patients. We do not use actually. We just use antibiotics for the patient when we are going with the pacemakers.
So then it is not needed. No, then it is not. If you're not using your any antibiotics before the procedure, it will not be needed.
No, what he means is see, for routine angioplasties, which we are doing, we are not using any antibiotic prophylaxis.
Sure.
Probably, maybe in the centers which are still reusing their material, should they develop their own antibiotic prophylaxis protocol?
No, I don't think so, because it is the infection control which has to be focused over there. The disinfection of the disinfection practice has to be robust. If that is not right, then any antibiotic is not going to prevent infection.
Can I step in, Neha, Dr. Neha?
Yeah, sure, of course, Dr. Suresh.
Suresh there. So I practices basically in Apollo, but other center is Madras Medical Mission. And Dr. Ulas Pandrangi is like a leading electrophysiologist. We do a lot of almost all the pacemakers and all AICDs and everything we do in Madras Medical Mission there. So the reasons we didn't find any infections, basically PTCA related infections in Madras Medical Mission. We do like a daily PTCAs and everything. But other centers who do PTCA, they got infected. Basically, we come across the things. So the reason is the re-sterilization policy, particularly single-use devices. People start reusing it. We're talking about the glutaraldehyde, that's fine. But the main reasons, in fact, we audited in one of the public sector hospitals where reuse is happening. They dip the catheters, everything appropriately in chlorhexidine. That's fine. Whatever disinfectant they want to use it, they disinfect, put it in the appropriate disinfectant for 15 to 30 minutes. Also, they kept it. But where is the problem? After removing the catheters from the disinfectant, instead of flushing with the sterile water or normal saline, they flush with the tap water. That is the reason for getting PTCA stent-related infections rather than putting it into the disinfectant per se for me. Yes, I agree. Glutaraldehyde is not an appropriate agent for the disinfectant for NTM. But the commonest reasons for laparoscopic ports as well as this type of stent infections, when people are reusing the same devices, single-use devices, they're putting in appropriate disinfectant. After removing from the disinfectant, they need to flush the disinfectant with sterile water or normal saline. But they are disinfectant with tap water. The housekeeping fellow take the machine out of the instrument, go to the tap, get the tap water, flush it. That's the main reason for this PTCA as well as other stent infections due to the NTM. That's one of the common reasons. We came across a lot of PTCA related infections, almost like 7 to 8 in the last 1 year itself. My intern is collecting the data. Mostly it is Pseudomonas or Staphylococcus. Rarely Serratia can happen. But whatever treatment, during the treatment, the infections can be controlled, but it needs surgery. Surgery is the way forward. People who are not going for surgery, they will definitely die. One episode they can clear, but immediately within 3 to 6 months, they got another infection, they succeed. They stumble to the infections there. So the way forward is remove the stent as doing the surgery. But unfortunately, doing the surgery is very difficult because my cardiothoracic surgeons can do multiple times redos, but they themselves find it very difficult to extract the implant, extract the stent inside the thing there. So what they do the bypass and keep the stent part bypassing it there. So it is not happening any further complications. So we need to do the surgery for save the patient's life. That's more important. And regarding some of the questions asked previously regarding the chlorhexidine wash on the generator site. Usually when you are reinserting the generator site, yes, chlorhexidine has got a good data. We can wash it off. But we don't have data for gentamicin or something there. But we got a good data for chlorhexidine wash. Once the generator site, you are replacing it, we also do the chlorhexidine wash at the site. If you wash with the chlorhexidine, the chances of infection is a bit less. And the PTCA stent infections is very difficult to treat, and we need to do the surgery. That's another key for it. Otherwise, excellent case, Dr. Neha, for excellent case series also for you.
Yeah, Dr. Suresh Kumar, one question from Dr. Shantanu Deshpande in the audience, and it's an important question because now many of the standard labs, if at all they want to use do re-sterilization, they use ethylene trioxide gas, ETO. And we at least have found when we used to re-sterilize, very, very unusual to get these kind of infections with ETO. So do you agree with that? Is it mostly with the liquid disinfectants that we see?
Yes, we need to have it. If you want to use the single-use devices, reusing, the best thing is the steam sterilizations or ETO or even H2 hydrogen peroxide. That is good. But the disinfectant is a middle level disinfectant. This is not a high level. This is intermediate level disinfectant, we can call it. Once you put in appropriate disinfectant, you need to remove and wash with the sterile water or normal saline. Don't put your tap water. Your housekeeping fellow does not know. You are a busy cardiologist. You are operating and you're putting a stent inside. You are not monitoring this one. But we as infectious diseases, we do infection control also. We go on audit how they're cleaning and everything. So at that point of time only we picked up. So ideal is either ETO, or ETO will take time. Hydrogen peroxide turnaround time is 45 to 60 minutes. Or steam is good also. That's no problem. But steam, sometimes it's melt because of the heat. So either ETO or hydrogen peroxide is a good one.
Okay, thank you. So, in the interest of time, I think
washing on tap water, I think, is a gross mistake. I don't think everybody does that because it is unheard of that you take out something sterile and wash with a tap water. I can't even believe it.
That's what happened in the audit, sir. We find out why. That's why it's not happening regularly. Some of the fellows who was not trained properly, if you post him in the cleaning department, this has happened. We did the audit. I audited for 2 hours, everything going perfect. I didn't find why the patients keep on getting it. Then finally, I start moving from the audit area. That fellow took the instrument and take to the tap and flush it. Then when I was waited for 2 hours. What is wrong with the procedure? Finally, I got it there. So this is routinely happening. Laparoscopic port is a common thing. Laparoscopic port is usually did by most of the housekeeping fellow. We got a huge case series of laparoscopic port, NTM site surgical infections, and almost all the surgical sites we came across NTM. So that is basically because proper cleaning is not done. And second thing, small centers, the experiences of the cardiologist is lacking. We found out why the stent infection, because of the multiple pokes, multiple attempts, they keep on dragging it there. That's other reasons we find out, and literature is also supporting people who got inexperience and they're not able to do the procedure in short while. They keep on dragging multiple punctures, multiple tries. That is one of the risk factors for stent infections.
Thank you, sir. Yeah, it's very interesting. Yeah, Milind, we can go ahead.
Yeah. So now we have Dr. Kaushal Pandey who is going to speak, and as we know, in so many cases the surgeon is the savior and the last resort for these kind of infections. So the next 10 minutes, sir will give us his perspective on cardiac device infections, and Dr. Kane sir will be moderating the session. Thank you.
Kaushal Pandey, everybody knows he is the most prolific surgeon that I know of. Largest number of cases in India, I would say, probably to the best of my understanding, because I don't think we have an audit, but excellent surgeon. Sir, please go ahead.
Thank you very much, sir, and thank you for your kind words. I'll just put up my presentation.
मैडम को भी पूछो और गीजर भी ऑन करो मेरे को नहाने का नहीं
Can everybody see my presentation, the first slide?
Yes,
sir.
So in this era, heart is the only organ after bone receiving so many devices. Each device is a challenge when we want to take out surgically for infection. Of course, prostatic endocarditis, both with mechanical and bioprocesses, is known to all of us. So I would not detail discussion on that one. Stent infection is a problem, and to my knowledge, it is the reuse of balloons which is causing them. So I am quite convinced reuse of balloons for dilating the stent should be banned. Pacemaker infections will continue to happen because there are a lot of technical issues into it. And of course, now with increasing use of MitraClip and of course TAVI, the situation as far as infections is concerned is actually very complicated. Prostatic valve endocarditis, the incidence fortunately is quite low, and it accounts for 20% of all endocarditis patients coming to Hinduja Hospital. We are a tertiary care center, so we get these patients from outside. They're classified into early and late. Early depicts basically presentation in the first year. And presentations can range from a small vegetation to abscess to valve dehiscence and sometimes even to atrioventricular disruption. From the surgeon's point of view, antibiotics can only buy you some time, but prostatic valve endocarditis is a surgical disease. This is a very interesting case which I definitely want to allude to. This is a 6-year-old girl who came to us almost 30 years ago from Mombasa, Kenya, and she had severe tricuspid valve regurgitation. We could not figure out the etiology. And at that age, we landed up with a 23 size St. Jude mechanical heart valve. This girl was being looked after in an orphanage in Mombasa. Unfortunately for the child, 6 years down the line, while she was doing well, the orphanage changed, the caretaker changed, and they stopped giving her warfarin. And of course, the valve thrombosed, and she was brought back to us in a very precarious condition. We did a redo mechanical heart valve, but unfortunately this time she required a permanent pacemaker. And then, of course, she did well, and then they stopped communicating with us. Last year, at the age of 32, she needed a change of pacemaker battery, the generator. So the doctors in Mombasa thought this is a small procedure, and the device was implanted in the epigastric area. So the local surgeon decided to replace it. Unfortunately, it landed up with very bad infection, which they treated for 6 months. And then, of course, the patient came back to us. Very difficult situation to be in. This girl was pacemaker dependent. So I requested my electrophysiologist whether he can put in a temporary pacing wire into the coronary sinus so that I can explant the device. The answer I was given was that the present temporary wires can never enter the coronary sinus, so that is not an option. And of course, mind you, patient has a well-functioning, good functioning tricuspid mechanical valve prosthesis. So we had a very difficult time as to how to handle the situation. So we explored the wound, debrided as much as we possibly could, and we removed everything except a small stump of the ventricular lead we kept because the patient needed to be paced with that. So we decided to pace, and we did a vacuum dressing. Patient did well for a few weeks. And we then requested, when the wound was very clean, we requested the cardiac electrophysiologist to put in a transvenous pacemaker through the coronary sinus. That was done while the wound was open. And of course, 10 days later, we closed the wound and the patient did really well. Stent infection, unfortunately, is a very common problem that we are seeing. It always seems to happen because of reused balloon. It's a major challenge. Sometimes the surgery can be very difficult, but it is absolutely mandatory to remove the stent. If you don't explant the stent, this infection will keep going till the patient is dead. Sometimes it can be very difficult to remove a stent because it's like trying to find a needle in a stack of hay. But with experience, you are able to find it. More often than not, the stent actually ruptures. So sometimes we have to take out, instead of 1, 2, or 3 pieces of the stent. But complete removal is mandatory for a successful outcome. Pacemaker infections, of course, are very notorious. Fortunately, we have good cardiologist team and infection control team at Hinduja. So we seem to be doing quite a good job, and we have very good outcomes with that. New devices are posing new challenges to us. I have not yet seen an infected mitral clip, but we have definitely seen infected TAVI valves, and it is a disaster, which is really a nightmare for surgeon. If it is a self-expanded design like a Medtronic valve, then explant is very difficult, especially in the infected situations. And all these patients actually land up not with aortic valve replacement, but with the aortic root replacement, because the ascending aorta actually gets eaten away. So implanting a TAVI valve in a young patient is a disaster. And I have always been pleading that TAVI aortic valve should be done only beyond the age of 75 or in patients who don't have a life expectancy more than 7 to 8 years. Take home message from my side is device infection, very difficult to treat. Surgeon has a very major role. Even after adequate antibiotics, we still need to intervene. We are convinced early intervention gives you better outcomes. After the removal of infected devices, please continue with antibiotics for 2 to 4 weeks. And of course, fungal endocarditis always requires lifelong antibiotic. And we've done at least 2 double valve infections with fungus. Patients have done well, but they need to take lifelong antifungal antibiotic, which is indeed a very costly experience. This is one of the stents which we have removed from an infected site. And this is the pus that you see when you are dealing with the infected stent. I think the rest I will discuss it out in the question answer session. Thanks very much.
Thank you very much, sir. Dr. Kane, sir, as a moderator, your comments, and then we can go to the panel discussion.
Of course, this is his presentation is excellent. My only question was, no, we know all this stent, and also luckily for us, we are using everything New York. So to be very frank with you, I have not seen at a stent infection in my practice, except one, and that patient, the primary angioplasty was done in Lucknow. Neha might have been at Hinduja that time, maybe. It was done in Lucknow. He landed up with infective endocarditis of aortic valve in Medanta. He was operated for aortic valve replacement in Medanta, then ended up in Hinduja with infective endocarditis of both mitral and aortic valve. I don't know whether you presented that same case or something similar was there. And then
it's
we had to
same
take
case.
out everything, but that patient could not be saved. But that patient came from outside. He came from a public hospital. Unfortunately, he had an infection there. But otherwise, in our practice, I don't know. I have yet to see a stent infection in my practice. I don't know about others. About TAVI infection, again, this is a new procedure. I fully agree with Dr. Kaushal Pandey that TAVI is to be done in patients who are elderly, above the age of 65 at least minimum. And doing it below that is almost criminal unless you have a very good justification. Patient refusing surgery is not a justification for doing it, because patients, you have to make them understand. All the people give reasons. Patient refuse surgery. Patient wanted TAVI. Arey, what, my patient will want anything and everything. So that is not no criteria. It is your job to convince the patient that this is not the age to do this, and you have to get a surgery done. So this is all my comments. So I think we can go ahead. Kaushal, thank you so much for showing us so many interesting facts about all these devices. So Milind, we can go ahead with the panel.
Thank you very much. So we have about 10 minutes for panel discussion, and Dr. Darshan Jhala sir is on the panel, and we also have Dr. Ram Gopal Krishnan himself. Ponde sir is not here. He had to go to Hinduja. Dr. Suresh Kumar, and then of course later all the panelists can chip in. So can I start with Dr. Darshan Jhala sir for his comments and any...
Yeah, so as far as pacemaker infections are concerned, except for superficial skin infections, any suspicion of pocket infection at all should not be lightly treated. Open up the pocket, take out the pacemaker, take out the wires. Don't cut the wires. Don't let them retract inside. That is not the way to do it. Clean the pocket up fully. And if the lead is a chronic lead, you will have to extract it. Extraction is being done regularly now in Mumbai. Dr. Navar has the best experience in this, but don't leave it alone. It's not, there is no easy answer to this. You have to bite the bullet and take the wire out. Otherwise, it will never ever heal.
To continue with the Dr. Darshan Jhala discussion, if the patient has pacemaker infection and if it is recurring, one option of leadless should be considered. I think 4 months back only with Dr. Milind, patient at Sion Hospital, this 14-year-old girl had multiple infection of pacemaker. At least she was admitted in the hospital for 6 months. And they were not able to treat this pacemaker infection. In that case, we used leadless and now she's on her own legs. So I think this one option should be evaluated at least in a patient, those who have a high risk of infection or those who have at least one revision of pacemaker such thought process should be thought.
But sir, Jhala, this is a very common. I have seen some patients. You put the pacemaker on the left side, infection ho gaya. You remove the whole thing, give antibiotics, make everything sterile. Put the pacemaker on the other side. After 3 months, patient comes again with an infection. So some people somehow whatever you do seem to be prone for infection.
Yeah, so that's what Dr. Kalkekar said. The absolute indication for a leadless pacemaker is repeated or even first time pacemaker infection especially if you have things like CKD, where they need the continuous venous access and where the patient is likely to get repeatedly getting bacteremia there. This is one single clear indication that you should put in a leadless pacemaker. They do very well, and now we have a leadless dual chamber option also coming in within the next year, so that even
Yes.
that problem is going to go away.
One question with the our doctor surgeon also. A lot of time, what happens? The infective endocarditis occurring with the wall, and surgeons are not comfortable operating on such patient. That is very difficult for us to. We try to convince, and but it's very difficult surgery for them also. How how we deal with that thing, sir?
Dr. Kaushal Pandey with us or is left? I
I
think
think he left.
Kaushal has
Okay.
left.
Okay. Okay.
Send
Yeah,
it
I mean,
tail operator.
Yeah, so I don't think so. I think once you have given what I realized with working with Rajiv Soman and now with Aisha, that you have to wait for the antibiotics to work. You cannot be in a hurry. So it's a delicate decision between the ID people and the surgeon and the cardiologist. It's a team effort to decide what is the right time to operate. Best is to wait for at least 2 weeks once you have a prosthetic valve infection. Is that correct, Dr. Ram Gopal Krishnan? What I'm saying?
Yeah, so surgery for prosthetic valve endocarditis is not done as always as frequently as it used to be. And the reason for that is our antibiotics are just better nowadays. We are achieving better microbiologic diagnosis, especially if there is a sensitive organism. You don't necessarily have to operate at all unless there is a mechanical or a conventional indication for surgery, like valve ring vegetation, etc. The most recent AHA guidelines have removed prosthetic valve endocarditis from a mandatory indication for surgery. They classify into urgent, emergency, etc. Prosthetic valve endocarditis per se is not an indication. Candida prosthetic valve, NTM prosthetic valve, yes, those are difficult to treat organisms.
And many a times, prosthetic valve endocarditis, especially if it is late onset, is also because of typical organisms like VGS, and they can be treated with effective antimicrobial therapy. So if the antibiotic choices are right, then they can really work well, and that can reduce indications for surgeries.
Milin, any questions in the chat box? Please see, huh?
No, I have an eye on the chat box, sir. No new questions.
Sometimes their wall dehiscence occurs, and in such patient, I don't think antibiotic alone will work, and they require surgery only. What is your opinion regarding this, sir?
Yeah, definitely. Any mechanical complication, you have to operate. There's no question.
We
Only
don't
the
need to operate that.
uncomplicated prosthetic valve endocarditis, which, as Dr. Neha said, with a sensitive organism, those cases don't need surgery anymore.
Any dehiscence which is more than 1/3 of the wall circumference, you require surgery. Less than that, you may put a device and close the rent which is there outside this thing. So we have done that in some cases. But if it is more than half of the or more than 1/3 of it, you better replace the wall.
I wanted to make one
Regarding
comment.
TAVI explantation, means we don't have an experience. I don't know if any one of you have an experience. And I have been following up the details what come in the literature. So slowly now surgeons there abroad where the number of TAVIs are much more, they are getting experience. So finally everything is an experience. How to remove a TAVI valve. And as Dr. Kaushal rightly put up, what is that? The self-expanding valve is a much bigger valve and it attaches itself to the ascending aorta. So to remove that is a big pain as compared to a balloon expandable valve, which is mainly at the aortic root only. So it is much easier to remove. But over a period of time, there are surgeons who say now we have the technique and we know how to do all these things. But it requires experience, I suppose.
I had a comment to make.
Yeah, please.
So just like your non-tuberculous mycobacterial stent infections are usually waterborne transmitted, we are seeing a lot of these TAVI caused because of some unusual organisms which are being transmitted through water only. I'll tell you, I'd seen a couple of them in last 6 months. One was Acromobacter dentrificans, which is again completely waterborne. Another one was Burkholderia cepacia endocarditis. So both of these are waterborne, and the third patient died because of an Aspergillus tower endocarditis. So so I think because the tower wall comes in a solution from abroad, I think I don't know, I've not seen that, but I think cardiologists may be knowing better. I think how do we normally how do we put that tower implant? Well, I think it is is it washed before you put it, or is it comes in a solution? So why should a person with tower get waterborne organism like Burkholderia cepacia and Acromobacter dentrificans and all that are usually all waterborne. So I think we are seeing this difficult to treat. Like Burkholderia cepacia endocarditis treating is a nightmare. Meaning none of it is. You may have antibiotics which are susceptible, but the antibiotics which are susceptible may not reach the wall. So that's a major concern. And as rightly said, all these towers are done at beyond 75 years of age or difficult surgeries. So once you have difficult surgeries means once you have tower endocarditis of a difficult organism, if you have to operate, it is not possible because it is done in a difficult patient who cannot be operated. So that's a major concern about this. So I wanted some comments from you all.
Nagvikar, I want to request you. Now, whatever you have said is something which I have not heard of. I'm in this field, but tower endocarditis, though we know it, but now that you have said you have seen it here, I don't think in our conferences, I attend almost all structural heart disease conferences in India. Nobody has ever presented a case of infective endocarditis of a tower wall, to the best of my understanding. I may be wrong. So please, can you publish this or do something about it?
I've got at least 5 cases.
This is 5 cases means it is like 5,000 cases to me, because the number of towers that we do are hardly any comparatively. You agree with me, Milin?
No, no.
Yes,
In
sir,
fact,
yes.
one of the cases is my case. Dr. Nagvekar has treated that patient. The patient 1 year after a tower developed not endocarditis, it was an aortic root abscess, periaortic abscess. And that patient responded completely very well to medical therapy. Now, why 1 year after the infection he developed, I do not know. I have no answer for that. But luckily, he responded well to medical therapy. Sir will recollect that case.
No, but this thing should be published so that people are more aware of it. Yeah, maybe I'm going to as a president of Mumbai branch now, we'll keep a session on this tower only with all this type of issues. Because
Provided people are ready to come forward and publish, because many people are not going to be
but
liking to present that.
once you do it,
I hope so.
but it's a news to me at least.
There is a question from Dr. Shantanu. As there is a rise in the stent infection, whether there should be a standard guideline put forward by CSI and ID for sterilization of these materials.
See, I'll answer that. I'll try and answer that. Shantanu, we all know that we, our seniors, and we have worked tirelessly to get Canadian guidelines and these guidelines for sterilization. When I was in 95, 96, I spent some time in Germany where they reused entirely everything in one of the best labs where Dr. Praful Kirkar was working there. So I had gone there, and they had a separate department of sterilization, which used to take care of everything. But by law, you are not allowed to use it. So where's the question of doing what you want to do?
Actually, sir, one more thing I wanted to add. The professor of microbiology at KEM had co-authored a set of guidelines, and these have been published in Indian Heart Journal, Protocols for Resterilisation. But when they were sent to the FDA for approval, the FDA has not given any comments on that. So as of now, we are in a legal limbo. From we can do something to resterilize, but legally we are not allowed to.
No, anybody who is using re-sterilized equipment, to the best of my understanding, is illegal in India. Dr. Jala, what do you have?
Sir, Dr. Yash Lokandala sir wants to ask some question.
Yeah, technically it is illegal. I just want to ask one very pertinent question. This I encountered somewhere. A patient had infective endocarditis of the aortic valve. He was treated. He was apparently free. 3 months later, somebody did a TAVI on this. Is this justified?
Pardon? What is the thing?
Patient was had come with a native valve endocarditis of the aortic valve.
Okay.
Was treated and 6 weeks later, because the blood cultures were negative, a TAVI was done on this patient. Is this justified?
No, but TAVI was done because of what?
Because of aortic stenosis.
The patient
Patient could have been operated. He was not a high surgical risk.
No, but he was less than 70.
He was around 70. That's not the point. The point is patient was fit to be operated. But patient's TAVI was done. Is this justified?
I believe so. It is justified. Why not? If he's 70 and if the
So,
patient.
sir, question is, patient had an infective endocarditis of native aortic wall.
Okay,
And
okay.
the same, sir.
Sorry, yeah, okay. No, I'm not very sure about your answer.
So instead of doing the surgery, here they opted TAVI.
Best would have been
considering
surgery
this
so that you remove everything and then put a new wall. I agree with you. I'm sorry. I made a
No,
mistake.
because I was quoted by somebody that after negative culture, it is okay to put in a valve. I'm not sure about it.
Yeah, I'm also not sure about it. Dr. Yash
Dr.
Lokapala
Gopal.
wants to ask something. How does he ask? Is he on the?
No, we are allowing him to come to the.
Please, yeah.
Allowing.
Did he come?
We are just told to allow him.
So,
Okay.
so here the indication was TAVI was mechanical indication or so basically if the infective endocarditis has been treated then and with appropriately, then the patient can undergo TAVI as well.
Dr. Neha, the thing is that if you
Yeah.
have a vegetation, maybe it may become bland, aseptic, but it's still there physically present on the valve. So if you do a surgical removal, then you are better chances of clearing off the whatever the vegetation, sterile or infected, and then you put a new valve. Whereas when you do a TAVI, you are just not addressing that issue of that vegetation which is already there. So that is the question.
Patient was not a surgical turn down. Was not a
No,
surgical
but any follow-up on that patient? How is it doing?
No, we don't know. We
Ideally,
don't know anything about this patient.
ideally infection should not decide whether it is a tower or sour.
Pardon? What did you say?
Infection should not decide whether patient should go for TAVI or should go for a surgical wall replacement.
Yeah, one way you can look at it is a treated infection. Maybe you can.
No, but this patient was not. This patient was not a surgical down. I mean, he could have done surgery. So my question is it better
So you
to
are
do a
entering into a field which requires extensive discussion. Dr. Jala will keep on one session on that.
Yeah.
Dr. Yash is here. Dr. Yash.
Yeah, can you hear me?
Yes, sir.
Yeah,
so
yeah.
One thing, the first this thing I raised my chat about infections with we were taught simple things. Am I audible?
Yes.
Yes. That when you wash up, I don't know if I can be on video, but I don't know. Anyway, when you wash up, that your hands should remain up. Half the time I see people wash up and their palms are below their elbow, means the unsterile water is trickling down back to their palms. The other sad part, the shocking part I see during someone is sweating, or their nose. I remember when we were in MBBS in the surgical OT, we were taught these basic things. So teaching is lacking.
I fully agree with what I said first only. That
Akane, you would have seen. See these things happening around you.
Yes,
people holding the mobile phone to their thing while they are doing a pacemaker. Means what nonsense are we talking about?
The people putting their hand through the gown and opening the door handle. I've seen that.
Absolutely. So let us look at absolute basics and then introspect that why are we getting these infections.
No, this is like, I'll tell you though. So I don't know at Reliance in Navi Mumbai, they have our microbiology department is continuously putting videos and they're doing it almost every week as if it is like a campaign. I don't know how long it will continue, but it's going on for last 6 months. And I'm impressed with that. So that has improved our washing.
Second, what question you asked, Kane, am I audible?
Yes.
About which antibiotic and how long. I'm reminded of Harrison's book that soap, water, and common sense are the best disinfectants. That you can give meropenem and you can eat caspofungin, but if you don't have basic cath lab hygiene, as told by one of the experts, and basic principles, then all these are futile.
Absolutely.
I don't think in KEM with Dr. Kale's strict protocol, even public hospitals, there are hardly any infections. So I don't think we, as told by one of the experts, not the immunity or the public versus private, it's this thing to detail, to basic principles, and that's the only point I wanted to make. Thank you.
Thank you, sir. So we are a little short of time, but we are going to be having a summary, a kind of summing up. So Dr. Neha will go first from their point of view, and then our own Dr. Amit Sanghvi, 2 minutes each, please. Your summaries and your highlights, what the takeaways are from today's session.
Okay, so then that means
Thank you so much. This was a very interesting and impactful session. And to summarize, I would say it's important to have collaboration between infectious diseases as well as the cardiothoracic surgeons and the cardiologists, because of course surgery has to be appropriate, and again effective antimicrobial therapy also needs to be chosen in the right doses and for the right duration. And again, most importantly, we need important is infection control and appropriate measures, infection control measures.
Thanks a lot, Dr. Neha. Nice summary. And Dr. Amit Bhai, can you please give our comments from a cardiologist perspective?
I think this is a mixed meeting between the cardiologist and the infectious disease specialist, and I think this was a great meeting. I have learned a lot from this, and I'm sure all the attendees are going to take a lot of take-home messages from this. So what we've learned is that infection, and the best thing is to prevent it. If you don't use biofilms, persister cells. We learned a lot of new things here, and all this caused difficult to treat infections. We might need multimodality testing, including TE, FDG PET, PET CT, and newer modalities of testing, which were elaborated in the lectures. But the most important thing is that what we need to understand is that if you get a device infection, then you need to remove the device, because without and only in very rare conditions where it's impossible to do it, probably you need to use long-term antibiotics. So I think we learned a lot from this. And again, reiterating what everyone has said, Dr. Yash Lokhandwala sir, Shantanu Deshpande, that prevention is better than cure. We need to, not forget our basics, and we need to definitely look at not causing infections.
Thank you. Thank you, Dr. Amit. I have to present the vote of thanks. And my boss always used to say, I have been given the thankless task of presenting the vote of thanks. But no, this time it is a very pleasurable task, because it's for the first time we have had a joint meeting with the CIDS or any society like this after a long time. It's been a very nice meeting. And I thank Dr. Kane sir and Dr. Nagvekar sir both for envisaging this meeting and making the whole thing possible. I thank Dr. Bhavesh, our General Secretary, all the office bearers of the CIDS, also our executive committee, in particular Dr. Neha for moderating the session so well. Distinguished expert Dr. Ram Gopal Krishnan sir, the Bhishma Pitama of Infectious Diseases Society in the country. And sir, it was great to have you. You're a wonderful talk, and thank you, sir, and please keep collaborating with us. I thank both the presenters, case presenters, Dr. Ponde's team with Dr. Parth and again Dr. Neha, very informative cases. And the icing on the cake was Dr. Kaushal Pandey's presentation at the end. No matter how much bravado we may have as cardiologists, ultimately in really difficult cases, it's the surgeon who bails us out. We must not forget our surgeons. I am also grateful to my colleague and dear friend Amit Sanghvi for helping me coordinate this meeting. I should not leave out Miss Ruth from the CIDS, who has been indefatigable, I would say, in all the work she has done. And I am very grateful to the panelists. I'm not naming all the panelists, but all the panelists and moderators. Many of them have stayed right from the first talk till the end and give us a very good perspective of this meeting. And of course, a very enthusiastic and participative audience, lots of questions, lots of queries, and that spurs us to have many such meetings in the future and continue our interactions. Sir, Dr. Kani, sir, any last words before we end?
No, I want to thank everybody. It has been an excellent meeting. I learned a lot, and I hope everybody learned. And thank you, CIDS, for collaborating with us. Our people, I don't need to thank because they're all our friends. We are all together anyway, but cardiologists are our members. So I hope everybody benefited with it. Thank you so much, everybody.
Lastly, just want to invite you all to learn more on infections. We have a Clinical Infectious Disease Society conference coming up in Mumbai and NCPA at its Nariman Point. That is 11 to 14 September. So we'll keep you posted on this. Thank you so much.
Thank you so much, everybody. Bye.
Thank you, everybody. Good day.
Thank you so much.